I would like to introduce Dr. Fabio Galbusera, who is affiliated with the Spine Research Group at the Schulthess Clinic in Zürich. He just recently moved there from Milano, where he was the head of the Laboratory of Biological Structure Mechanics of the IRCCD. He received his degree in biomedical engineering at the Politecnico in Milano and his PhD at the Institute of Orthopaedic Research and Biomechanics Center of Musculoskeletal Research in Ulm in Germany. Whenever you're ready, you may start.
Thank you. I think I need my presentation or computer. Yeah. Okay, great. Thank you for the introduction. I also thank you for the invitation. I'm really happy to be here in these days to show what we are doing and also to see what the others are doing. It's really a great event. I have nothing to disclose. I'm an engineer actually, but I've been working for the last 18 years in a hospital. So my research is really clinically oriented. And many of the things that will show you have a different perspective from what we have seen before or from the other presentations, because instead of starting from the basics and trying to build models and then try to, let's say, get to clinical relevance later, I go the other way. So I start from a clinical question and I try to build models or to select the best tools in order to answer that specific clinical question. Since I'm working in a hospital, the questions come directly from the surgeons or from the physicians, and of course, computational models are great tools in order to try to give answers to these questions. A very brief introduction about the spine. I will go very quickly with that because I know that many of you are working on the disc on the spine, so then you know quite a lot, but I still would like to focus on some aspects because I'm going to talk about some specific implants that are used for spine surgery that not everybody of you might know. So this is the spine. We have the three different regions, cervical, the neck, thoracic, the trunk, and lumbar. And yeah, we all know that we have different curvatures, lordotic and kyphotic, and so on. That's a section of a vertebra, lumbar vertebra. We can see that we have these trabecles, which are oriented in a vertical direction. Actually, they are vertical because the load is vertical. The most important load is vertical, so the trabecles try to resist this load by using the principle of the lightweight construction. The most interesting structure in the spine, I think most of you also agree with me, it's the disc. That's a section of a lumbar disc here. We know that we have two regions, the nucleus and the annulus around this, and they are both very rich of water. And the nucleus especially is also rich of protoglycans, so that gives the nucleus the capability of attracting water, so to create a pressure inside the disc, even in the absence of any applied load. And the annulus is made of collagen fibers in these layers that we can see here that basically contain the nucleus and try to avoid the bulging of the disc under compressive load. Here we can see some nice slices, so pictures taken by cutting human disc in the half that can show that the disc actually is not always in this great, very wonderful condition, but can undergo degeneration. Actually, most of the people will have a degeneration. So if you take an MRI, especially if you are 40, 50 or older, you will see that many of your disc will show some signs of degeneration. We can see some example here. We can have height loss, we can have some tears inside the disc, or even disruptions completely, or the sclerosis of the end plates, or the osteophytes, which are these bony beaks that basically grow in order to try to stabilize the spine. And it's very important to note that these discs may look very different in different patients. So there's a huge variability about how the disc degeneration can be seen in different patients. So how does the biomechanics of the disc work? That's a very simple scheme that shows the general behavior of the disc under load. So we said that the most important load is a compression. In a healthy disc, we will have a creation of pressure inside the nucleus, and this pressure will basically create a tension inside the collagen fibers in the annulus, and we are going to have a quite, let's say, nice and smooth distribution of the stresses along the end plates. In a pathological disc, in the degenerative disc, typically we have a loss of proteoglycans. So the disc is not able to absorb water, it's not able to swell, so to create a pressure inside. So under compression, we are not going to have a pressure in the middle, and we are going to have buckling of the fibers and stress concentration in the transition between nucleus and annulus. And this stress concentration can be really painful for the patients. This was demonstrated in several studies. That's a very famous study from the 90s, Japanese study, and the principle was very simple. So sticking a sensor which is able to measure the pressure in the disc, in the middle of the disc, for different degrees of degeneration. And we can see clearly that with progressing degeneration, we have a very strong decrease in the pressure that we can measure in the disc, in vivo actually. These are in vivo data in the human patients. There are also very nice series of study that I think that everybody working with the disc knows from the group of Adams in Bristol. And they used these long needle sensors which are able to measure the pressure along the whole disc from one side to the other side. And these are done in cadavers, of course, because it's too invasive to be done in living human patients, but in living human patients. But in cadavers, you can really measure the pressure from one side to the other. And these measurements showed clearly that in good disc, we have a homogeneous pressure everywhere, especially in the nucleus. And with the degenerated disc, we have these pressure concentrations here between transition between nucleus and annulus. And they said, these pressures here can be really painful. So let's move a little bit about spine surgery very quickly. Spine surgery is used to treat different pathologies, degeneration. We see that clearly here in the MRI. We have a black disc. That means that it lost water. So in MRI, black, in a T2-weighted MRI, if the water appears white, so if the disc is not white, so you see the others are white, this is black, that means we have no water. And it's also protruding and compressing the spinal cord. That's a painful thing that needs to be treated. Then we have trauma, fractures, you see here. We have a case of deformities. That's a case of scoliosis. That's a case of sagittal imbalance. It means that the patient is not able to keep a correct position in standing, and this creates problem in, for example, with the gait. I will show you an example of a model about the treatment of this pathology later. And then we have, of course, tumors where you basically need to replace vertebrae, especially metastatic lesions. The golden standard for spinal surgery is the fixation with the screws and rods. So basically, you put screws in the pedicles. These are called pedicle screws that you see here, and you block the screws with these rods, posterior rods. And this basically, the idea, the concept is to create a fusion. That means create a single block of bone by having bone growing through here in the posterior and in the anterior zone, so that we remove completely the motion and we remove any pathology. And after a successful fusion, the patient will feel no pain anymore. And we also use the cages. These cages basically can be filled with bone chips or with other materials, and basically they favor the growth of bone from one side to the other, so that this becomes a single block of bone. And spinal fixation and fusion can be used for the different pathologies. So you see an example here for trauma. This vertebra is broken, and we have like a bridge fixation across the vertebra. That's a degenerative case. You see that the disc was removed, replaced with these cages, and then we have a fixation across the level. Case of tumor, a vertebra was completely removed, replaced with a long cage, and then fixation. And in the case of scoliosis, that's the same patient before and after the surgery. You see that by using many screws and long rods, you can really correct the deformity and make the spine, which was not straight, make it straight again. So it's really, really effective. I mentioned briefly the cages. There are different models of cages which depend on the direction that you put in. So you can come from the back, posterior fusion, or through the foramen, that calls transforaminal, or anteriorly from the front. That's about the lumbar spine. The cervical spine is a bit easier because we can go from the front very easy, so we can also put some plates. That's just a quick mention. And another philosophy of treating spinal disorders is using motion preservation implants. That's an example of artificial disc. So here you don't try to make a fusion. Here you try to put something that is able to continue moving after the surgery. So it's something that preserves the motion. Here you see some examples. There are many examples, many different models on the market. It should be noted that in the lumbar spine, they should be implanted through the anterior direction because they are so big that they cannot be implanted from the back because of course there is a spinal cord. And this implantation is a complex surgery because you have to basically dig through the belly, move the aorta, move many vessels and so on, and this is associated with quite a high risk of complications. So it's a complex surgery. While the standard, the fixation and fusion, it's much easier surgery with less complication. But still, you can preserve the motion somehow. In the cervical spine, it's easier because it's very easy to get access from the front to the neck. So it's basically the same surgery, same models of artificial discs, but it's much easier. Actually, that means that this type of surgery is more frequently used because it's easier. There are less complications for the patients, less blood loss, and so on. So this make things actually easier also for both the surgeon and the patient. The last type of implant I would like to mention, because I will show an example of these implants later, it's dynamic stabilization. So dynamic stabilization, it's like standard fixation with screws and rods, but instead of using a metal rod, a rigid rod, we use like a cord that is able to preserve some sort of mobility of the spine. So here the idea is not to create a fusion across the different levels, but just to put something that is able to increase the stiffness of the spine so that we can avoid some, let's say, extreme positions, extreme motion, it's called instability in the jargon of surgeons, that can actually create pain and discomfort to the patient. So make the spine a bit stiffer without creating a bony fusion. And yeah, that concludes basically my brief introduction about the spine. And I think we can start now talking about models. And to talk about models, I would like to start with an example, like a practical research question, and see how we can try to study this research question using different approaches and see why modeling actually is useful for our case. And the question that I have is, we want to measure the stresses in one intervertebral disc in the lumbar spine during different activities like standing, motion, flexing, carrying loads, or whatever. How can we do that? The easiest way actually is to put a sensor. So that's an in vivo approach. We put a sensor in the disc. That was done several times in the past, actually in living human patients. Now it's a little bit more complicated because, you know, the ethics regulations becomes more and more strict. And it's correct that they become strict, I would say, but still in the past it was relatively frequent that we had this type of studies in human volunteers. That's an example. That's a sensor in the middle of the disc, you see, and it's able to measure the pressure. And that's a great thing because actually you can really measure a stress in a living patient. You can ask the patient to walk or to jump or to run or whatever, and you have the real thing. So it's the real quantity that you want to measure. But we have some downsides. As I said, we have ethical constraints because, of course, making an operation in a human volunteer, it's something that it has some ethical limitations. If we do that with animals, we still have ethical constraints because of course, even using animals has quite strong ethical constraints. But if we use animals, we also have the limitation that we are actually using a model. For example, if we decide to use a sheep is standing on 4 legs, not 2 legs. So the pressure that we are going to measure in a sheep is going to be different from the pressure that we are going to measure in a human, I guess. So we have to take into account the limitation of the model that we decide to use. And the other big disadvantage is that some quantities are not measurable. We can measure the stress, the pressure in the middle of the disc, but we cannot measure, for example, the strain in the collagen fibers. We don't have the sensor to do that. We don't have the technology. And so we have a quite, let's say, limited choices of the type of outputs that we can measure. Another approach is to use a cadaver. That's also very popular, done very frequently. That's an example of a cadaver of a lumbar spine mounted in a machine. The machine is able to apply some loads. You see this machine here. You have some motors that are able to apply some motion to the spine. And the idea is the same. So you have a spine. We apply some sort of loads, physiological loads that more or less mimic the loads that are that are used, so the physiological loads that we have in vivo. We are still working on real specimens, so we are still in the, let's say, the real thing. And we have an easier access to the outputs with respect to the in vivo measurements because we can put more sensors, we can use different sensors, we can even damage the spine more, even if we need to make some lesions in the spine because it's a cadaver. So I mean, it's something that it's easier to work with. We should not be worried that we are creating some damage to the patient. But we have bigger limitations. So we are applying loads with motors, and these motors or whatever we are using, dead weights or whatever, they might not apply the same loads that we have in vivo. So we are working with a model. We are in laboratory conditions working with a model which might be different from the in vivo stuff. There are also some practical limitations. So the specimens are difficult to obtain. They cost a lot of money. So managing human specimens, it's quite expensive. You have to order from other countries. You have to store them to manage them with the right laboratory condition. There are rules. So it's a complicated thing. And most of the specimens that you get are in degenerative conditions. So you don't get, if you need healthy discs, you order 15 spines, you probably get 10 spines which are in very degenerative conditions and 5 which are actually in a good condition. So yeah, you don't really have much control on what you get. And the other thing is that there is strong anatomical variability. So you get different specimens, and the specimen might be really different one to the other, and this can create some, let's say, reproducibility issues. So it appears that the next, let's say, logical step is to use a model. We could use like an analytical model like this one, basically draw down the forces, using the standard equations of equilibrium and so on, so to calculate. Then we can still calculate the stress that we have in this point. So the same outcome that we had at the beginning. Big advantage, it's quite easy. We don't need patients or specimens, so we have very big advantages. Cheap. And the big disadvantage is that we are even more in a model condition. So we have even more simplification assumptions, and this might actually lead to results that are quite far away from the measurements that we would have in vivo. Actually, there are many of these models in the literature. That's an example. This is a model. You see, this is the vertebra, this is the nucleus, and this is the annulus, and we have all the equations, and this model was solved analytically. So if you look in the literature, especially in papers from the 80s and the 70s, you can find many analytical models in which they use the equations in order to calculate values similar to what I showed before. Next step, of course, is using a computer. If we have a computer, we can still make a mathematical model, typically finite element model, and use the computer in order to solve these millions of equations that we are going to have. And yeah, the computer makes it very practical, make it very accessible. And we still have simplifications and assumptions, but the model can be fairly complex. And the more the model becomes complex, the more we get closer to the results that we would have from in vivo measurements. So I will now show some, let's say, early examples of models. That's a beam model. So if you have a look in the, let's say, old literature, you will see many of these models. That's a model of, you see the rib cage plus the whole spine. From the lumbar to the thoracic, we don't have the cervical spine, but see the model of the whole trunk. And you see that beams were used to replicate, so with one single element, you replicate the behavior of the whole intervertebral disc. So we have quite strong assumptions here, but still I think that these models were, let's say, very important, both from a historical perspective, but also, I think, from a scientific perspective, because many of these results that are published in these models are still very useful today. Then we have the axisymmetric models, also, let's say, staying in the old days. That's basically, we exploit the fact that vertebrae and discs are somehow cylindrical. They are axisymmetric, so they have symmetry around the axis, the axis. So if we make this 2D model and we imply that the model is symmetric around the axis, we can somehow approximate the 3D behavior of the vertebra and the disc without having a full three-dimensional model like the one that we use today. Also very important papers that with very, very, very relevant scientific results. That's a very famous paper, I think, of a famous series of papers. So it's the papers by Shirazi Adl, starting from the 80s. These are among the first full 3D models of the lumbar spine, starting from motion segment. You see they didn't use many elements. It's not fully anatomically accurate, but still using model like this, actually, if you read these papers from 84, 86 today, you still find a lot of information which are still up to date. I think many of these old-time papers are, I would say, better than many of the modern papers, which very anatomical, realistic models, but they don't say much. Here, really, the contribution to science that we had from these models and these papers is really huge. So I'll now show you some examples from, let's say, modern model that was developed in 2006 by my former colleague and also friend, Hendrik Schmidt, in the University of Ulm. It's a model of L4, L5. So the idea is starting from a specimen, human specimen. We have vertebral 4, L5, and the disc. Take a CT scan, perform a standard 3D reconstruction, and then building a model, a structural model with only extrahead elements. And this model was used in many papers. So if you know the literature from the University of Ulm, you will see that exactly this model was used, modified with implants and whatever for really like, I think, at least 20 papers. It was also very carefully validated. I'm not showing the validation today, but it's the validation that was done against data from cadavers was really fantastic. So we can, of course, use the model to calculate the displacement response. Here we have a constraint on the bottom, so that the low end plate of F5 is fixed, and we apply a pure moment on the top of F4. So we can use the model to calculate, for example, to see how the disc is bulging, flexion, so things like that. Calculate the range of motion, which is a very important parameter to study the biomechanics of the spine. We can also calculate, for example, the stresses. Actually, this was supposed to move, but yeah, it doesn't matter. So, for example, we can here calculate the pressure that we have inside the disc instead of measuring them. Or we can also calculate some parameters which are, let's say, more difficult to be measured experimentally. So there are some, for example, two examples here. The point here, the dot, indicates the center of rotation of the spine going in flexion and in extension. And this is something that you can measure actually in vitro by applying some markers and using techniques as the standard methods. But it's so, let's say, dependent on measurement errors that we are going to have quite high imprecisions if you try to measure that in vitro. And with the models, of course, we have a much cleaner result. And if the model is valid, then we can really get something more from a model than what we would have from an in vitro testing. Another example of the variable which is basically not accessible from in vitro testing, also in vivo, of course, is the force in the facet joints. So you see here this chart that indicates how the facet joints are touching and the force which is exchanged to the joint when we go into extension. And this is something that is basically impossible to measure in vivo or in vitro. We don't have any technique which is able to provide this type of estimation. We can, of course, modify the model and put an implant. So you see that the disc was removed, and instead of the disc, it was implanted, let's say, virtually an artificial disc. That's the first artificial disc that was presented on the market in the 80s. It's called the Charité disc, and it's made of polymeric nucleus plus 2 titanium end plates. And with the model, we can calculate how the spine is moving and to compare also the results of the motion, center of rotation, and whatever with the results that we have for the interspine. And of course, we can also perform stress analysis. So you see, it's the same model. We see here we can use these calculations to localize, for example, the points where we have the higher stresses in the core, which are the points that will be more subject to wear in vivo. So, for example, so many access to many variables that are very difficult to estimate or to measure with our tools, with other tools. That's an example of a practical case that was also performed by Hendrik Schmidt in Ulm. So Hendrik built this model with the spine with the Charité, and then the group was approached by a company from Israel, and the company was developing a new disc prosthesis. That's a model. It's quite similar to the Charité, but you see that we have two different radius of curvatures. And so they asked a precise question: do we need these two different radius of curvature? So what's the effect of making different radiuses? And do we really need that the core is able to move in the lower plate or not? So different questions that are quite difficult to be investigated in vitro or in measurements, but it's something that you can do quite easily by using FEM. So we'll show briefly some results you just mentioned. Here we see the range of motion. So the green line indicates the range of motion of the intact spine. Here in axial rotation and inflection for the three different models. So the Charité, the standard one, the new one with the mobile core, or the new one with the fixed core. So like, let's say, gluing the core to the lower plate. You can see that in axial rotation we have quite a good approximation of the flexibility for all the three models. Inflection, they are all quite similar again, but actually if you want to have a correct range of motion, a physiological range of motion, you should try to push a little bit the prosthesis in the posterior direction, because if you put that into the center of the space, you are going to have a little bit less flexibility than what you have with the intact spine. So here's another comparison, just to make an example. We have the position of the center of rotation in axial rotation. You see that actually this is quite different from the original one. So you see that with the three models, we have a center of rotation that stays quite close to the center of the disc, while the intact one will basically approach the facet joint the more we move. So this shows that actually this type of discs might not be great in replicating the motion, the real motion of the spine in axial rotation. I will now show another example, still made in the same group in the same years, and this is about dynamic stabilization. I mentioned you already this device, which is basically aimed at increasing the stiffness of the spine in order to limit this instability that can be due to degeneration of the disc. And a company came to us with a very precise questions, and they wanted to develop a system like this, a new one. And they asked, they wanted to know which is the stiffness that they need to give to the implant in order to have a range of motion which is more or less in the middle between the intact range of motion, so the range of motion of the normal spine, and the range of motion that you would have if you have fixation. So try to estimate how stiff should the implant be in order to have this increase of flexibility, this decrease of flexibility. So basically there are two parameters that we can control, the axial stiffness and the bending stiffness, and Hendrik again ran some models in which he changed both parameters, so the axial stiffness here, the bending stiffness here. You see that here we are in flexion. The bending stiffness doesn't do much actually in this case, so it really doesn't change so much the range of motion that you have. The axial stiffness is a much more important parameter. But if we want to be really effective in, let's say, reducing the range of motion by half, we have a relatively narrow range of values that really allow us to control the range of motion of the spine. Because if we increase the axial stiffness a bit more, then basically the range of motion becomes very small. So at the end of the day, we took out a couple of parameters, and we gave them to the company. The company made this titanium spring, let's say, which has exactly these flexibility parameters, and they made a prototype, and they gave back the prototype to us. And the prototype was used to make some tests in the human cadavers. So basically, we compared the flexibility with the new implant with the flexibility that we have with the standard fixation. And these are the results that shows very nicely that you see in green we have the flexibility of the intact spine, in this light blue the flexibility of the rigid fixator, and the new implant is in the middle, so exactly what the company wanted. So using a model allowed us to have the mechanical behavior of the implant that was required by the company. Actually, this story goes on a little bit because Then the company gave this prototype to a surgeon. The surgeon took the prototype in his hand and tried to press on it and say, it's too soft. And the company changed it with the stiffness, of course, because apparently they trusted more the judgment of a surgeon with the hands than like 6 months of study with fine interval modeling. But these are things go, you know. Yeah, so, and then now I would like to talk about another case. That was a case which was a model which was developed in the Politecnico in Milano a couple of years ago in a PhD study, and it's a very, let's say, relevant case from a biomechanical point of view, and it's a study about PSO. PSO, it's pedicle subtraction osteotomy, and it's a treatment which is used to treat sagittal imbalance. You can see a case, so it's the same patient before and after the surgery. You can see that here the patient doesn't have the correct S shape of the spine, but he has a C shape of the spine. And the lumbar spine is not lordotic, but it's kyphotic. So the surgeon tried to reconstruct the correct lordosis of the spine by using this technique that you see here on the right. So basically, if you cut away this wedge of bone, you close the spine like this, you can create locally a very high lordosis. And this is very effective. You see here that after the surgery, the spine looks much better, much more realistic, much more physiological, let's say. The problem that you have is that if you cut away a big part of bone here, you create an instability, and this spine is going to be unstable. So of course you need a fixation, but here the load will go on the rods and not so much on the fracture that you are creating. And this basically means that the rods are breaking. In 20 to 25% of the cases, we are having a fracture of the rods. It's a big problem. So what we tried to study with the finite element model is if we can do something in order to reduce this rate of fracture that we have in the rods. So it's reported in the literature up to 39%. We are in our clinic more close to 20, 25%, but it's still a big number. If 25% of your patients will have a fracture of the rods, it's a big problem. So what we tried to do is to see if we can do better by, for example, changing the material of the rods or the diameter. Is it better if we use bigger rods or if you use 4 rods instead of 2? So just double the rods to see what happens to the rods. And if we decide to use 4 rods instead of 2, where should we put the 2 additional rods? It's not a trivial question. So you can put that in different positions, and this might have an effect on the biomechanics of the contrast or of the construct. So this is the model. It's a model of the lumbar spine, including a part of the sacrum. It's quite simple, actually. We have a fold-over load that creates basically the body weight, replicates the body weight that we have in vivo, plus some moments that create, let's say, flexion, extension, bending, and so on. And we use the model to calculate range of motion, the loads on the rods, and also the loads that is passing through the fracture here. Here we have the osteotomy, and also the stresses on the rods. So here you see the model before the surgery, and the model with the osteotomy here in L3, in the vertebral 3, and in the vertebral 4. Why 2? 2 because actually the surgeons are using this technique in L3 and in L4 for different patients. And we thought about, do we have a difference in the biomechanics if we do the osteotomy in a different position? Does it change something? Actually, the answer is no. The results are more or less the same, but we wanted to test if we have some sort of effect of changing the position of the osteotomy. So this is quite a trivial result, I would say, because this is the effect of the osteotomy. If you just make the osteotomy without adding any fixation to the spine, we have an increase of the range of motion. That's normal, of course. We cut away some part. The spine becomes more unstable. We need stabilization. We knew that already. These are the models with the fixation. You see that's the model with the single rods, so the standard rod fixation. That's the model with the double rods. So you see that in addition to the main rod, we have an accessory rod which is connected. So that basically spans only the part where we have the osteotomy, which is connected to the main rod, but use these implants which are called dominos. So here we have the osteotomy in L3. Here we have the osteotomy in L4. It's the same single and double rod fixation again with the rods only, double rods only across the L4. That's a chart that shows some results. So the forces that we have in green on the anterior part, so in the force through the osteotomy, and the force through the rods. Actually, it's quite interesting to see that whatever the configuration that we use, the force that we have in the anterior spine, it's always bigger than the force that we have on the rods, which is a good thing, actually, because if we want to have a healing of the fracture, if we want to have a fixation of the osteotomy that's created, we need to make some load pass through it, because if the bone is unloaded, we will not have fusion. So in order to have fusion, we need load. So it's good, it's very positive to see that the big part of the load will go through the anterior spine. And of course, you can see there is some effect of the diameter in the rods. So if we have a smaller rod, we have an increase in anterior part, which makes sense, of course. If we have double rods, we have, let's say, a decrease of the load in anterior part and an increase of the load on the rods. This doesn't say anything with respect to the risk of failure. So if we want to evaluate the risk of failure of the rods, of breakage, we need to look at the stresses. And here are some charts about the stresses. That's configuration with titanium rods, single rods, 6 millimeter and 5 millimeters. We see that there is an increase. If we decrease the diameter, the maximal stress in the rod will increase by approximately 10%, which is quite a lot, actually. This is a conditioning flexion. We just have, I will just show flexion to you because we demonstrated that flexion is the condition in which we have the highest stresses. So it's the most relevant for this type of analysis. What happens if we change the material? Titanium, so here we have the same diameter, titanium versus cobalt chrome, much bigger stress for cobalt chrome. This makes sense because, of course, cobalt chrome is stiffer than titanium, so it takes more load on it. On the other side, does it mean that this is less safe? No, not really, because it's a different material, so it has a different strength. So, it appears from other studies that the fatigue strength of cobalt chrome is better than that of titanium. So even if we have higher stress, it doesn't mean that we are going to have higher risk of failure. Actually, clinically, we see that we have more failures with titanium than cobalt chrome. What happens if you use double rods? We have a big decrease in the maximal stress. So using double rods is really an effective strategy in order to reduce the maximal stress and then also the risk of failure. So if we want to use the double rods, where should we put the double rods? So we have different possibilities. We just studied these 4, but there are many other possibilities. So we can put it here in the say, internal medial direction, or can go outside, or can go backwards. And it has an effect on the maximal stresses. You see that the maximal stress in the rods change quite a lot if we use different configurations. And actually, so we saw this result and we said, yeah, so these 2 are the best ones. So they should go backwards or outside. So we went to the surgeon and told the surgeon, you should do like this because this is the best for biomechanical point of view. And the surgeon said, no way, I cannot do like this because if the rod goes backwards on outside, then the patient will feel it with the hand. It's going to be painful, it's going to create inflammation. So even if the stresses are higher, I have to say that I must use this type of technique. And that's, sometimes the biomechanical aspect is less relevant than other aspects which are more relevant for the safety and for the comfort of the patient. Another idea that we investigate is use cages together with rod fixation. So the idea is quite simple. So if we put a cage above or below, or above and below the osteotomy, we make the anterior spine stiffer. And making it stiffer, we shift the load from the posterior to the anterior direction. And shifting the load anteriorly, we decrease the load in the posterior direction. That's the hypothesis that we should decrease the stresses that we have in the rods. Does it work? Yes. So we see with no cages, we are around 200 megapascals, with a cage 150, with 2 cages 100. So yeah, using cages, it's effective. And actually, now it's done clinically. And this paper was one of the first papers that proposed this solution. So we are happy that we could really contribute to make a change in the clinical practice by suggesting a solution that actually it's appearing to be valuable from a biomechanical point of view. So that's a summary of what we said already, changing material, diameter, double rods and cages. So it appears that double rods and cages are effective strategies for reducing the stresses that we have in the rods, and that's protecting the rods from mechanical failure. Yeah, that was the conclusion of the study, and 1 year later we were able to get some funding from the SRS, Scoliosis Society, and we decided to use that money in order to replicate the study in vitro. So here is an example. So that's a lumbar spine. Here you see the double rods. That's with the single rods. You see the osteotomy here, also with cages. So basically we replicated all the conditions that we did with the model. And you might ask, well, why do you do that again? So you have results. Why should you do that in vitro? You have already finite element models. Main reason for the validation. So we made models. We validated the intact model, but we had no validation for the implanted model. So having a confirmation of the results is something which is very valuable. Also because we have to remember that in the models we have strong assumptions. So there are many things that we are not really able to replicate in a correct way. So being able to replicate the study in vitro was really very important. Also, another reason is to take into account the intersubject variability. So the model was one subject. In this study, we were able to get 7 spines. So we are somehow able to perform some statistics to see if what we get in one patient can be generalized to other patients. Next question is, why didn't you do this in vitro study first? So if seems to be so better, actually. It's not better, but FEA is cheaper. So if you start with no money, the easiest way is to start with a model, and then let's see how it goes with time later. If we get money, you do that again, or otherwise not. So, but there are also other reasons, actually. With finite element models, we can calculate the stresses everywhere in the model. If we do an in vitro test, we have to put strain gauges or to use some special techniques, and that means that we have access to some variables, only some specific points. So we have a better view of the biomechanics with the model because we have a complete access to all the outputs. And there is also another reason which is also quite important. So we used 7 spines to test different conditions. That means that for each spine was used several times in different configurations. So we had to repeat the study by making incremental defects, so adding one implant, removing one implant, and so on. And this repeated testing and making changes on can damage the specimens with time. And this is something that we do not have with the finite element model because, of course, in the model we can modify the specimen how many times as we want without creating, let's say, propagating this damage and accumulating damage. So here are some results. Here you have configuration with 2 rods with the osteotomy here in the middle. We also tested this configuration in which we have 3 rods, and the 3rd rod that you see here is connected to the laminae using a hook. So it's not based on pedicle screws, it's based on a hook. So we have the 2 rods fixed with the pedicle screws and the 3rd one with the hooks. And then we have the 4-rod condition. And of course, we are not able to measure stresses in vitro. We have to measure strains, and we measure the strains using these strain gauge rosettes. Here's some results. That's the range of motion. It's quite clear that all configurations are very effective in reducing the range of motion because, of course, we are adding screws and rods, so that becomes stiff. But the interesting thing is when we look at the strains in the rods. So you remember that using double rods with respect to 2 rods more or less reduced the stresses by some 50, 60%, and it's exactly the same that we could measure here. The cages gave results which are quite similar to the 4 rods. Again, very close agreement with the finite element results. And 4 rods plus cages, it's a very effective condition and really decreases the stresses in the rods by far. And this 3 rods configuration with the hooks, it's rubbish. It doesn't help at all. Adding the third rod with the hooks doesn't protect the two rods at all. So it's really, I would say, wasted time. And actually nobody's using this technique anymore, because also clinically it was shown that using the three rods configuration doesn't reduce the risk of failure in the two main rods. We were also able to get some fracture rods, so real rods from a patient. That's a patient, one example. So it's a patient which had fractures in the rod. You see them here. So here and here. Actually, that's a two-stage operation. So first the patient was operated for scoliosis in thoracic spine, and then later the surgeon added the lumbar surgery with the osteotomy here. And after 4 months, I think, after surgery, they had a fracture in both sides, left and right. We were able to get both rods, and we were able to analyze the rods with these confocal microscopes. And yeah, actually one rod doesn't tell us much, I would say, because you see here the two fragments were very close in vivo, and they touched each other, and they scratched the surface. So the fracture surface doesn't really say anything. It's just, let's say, polished by the motion after we had the fracture. But the other one was quite far away, and we can see clearly that's a typical fatigue fracture. If you know something about fracture mechanics, you will recognize that it's typical fatigue fracture, starting from here. Then here we have the propagation, and here we have the rough surface that indicate the final rapid fracture. And it's very interesting to note that the fracture started in the posterior position, which is exactly where we predicted that we have the maximal stress. So that's also another way of validating the model once more. Yeah, that concludes my presentation. Thank you for your attention. I would be happy to take any questions.
Thank you very much for this great and very interesting talk. Are there any questions in the audience or online?
Thank you so much. First of all, I actually have also a couple of questions. First, regarding like inserting a sensor into the IVD to measure the pressure, how sure are we that like the act of measuring isn't increasing the pressure there? Like, for example, after doing the surgery, we're doing a cut to insert the instrument, and we have like a bulge now around the sensor. Isn't that affecting the pressure overall when we're sensing it?
Yeah, I'm afraid that we don't know that, because there's no way to quantify this. Yeah, actually, it's a limitation of the study. I think it's written in the paper that the surgery might have an influence of the stress, but I'm not aware of any estimation of the importance of you're right, that might be a change, maybe big, maybe not, but I'm not aware of any, let's say, trial to estimate the size, the effect size of this effect.
And for the cross-sectional area of the rods that were used, yep, were they also optimized for the design, or were they just taken as circular rods? Because like from a mechanical engineering point of view, like a solid circular rod is not the best for bending.
They are circular rods. They in the clinic practice, they use the circular rods mostly. There are also other type of sections. There is another rod commercially available, which is called omega rods, which has the shape so it's circular plus one border on the bottom. Yeah. And they are actually interesting. The problem is that these rods are bent by the surgeon inside the OR. So during the surgery, they have a tool that is able to bend the rod to the shape that you need. Okay. And with the circular rod, actually, it's easier to bend the rod with the shape that you want. And also, when you bend the rod, you should be careful not to create local fractures or micro cracks that might later become fatigue. So if you have strange cross-sectional areas, this might create some stress concentration that may fail later. Okay. There is a new trend, but very new, quite expensive, to order patient-specific rods from the manufacturer. So you send away the CT scan or X-rays, and they design and they manufacture the rods for you already with the right shape that you want to use with the patient later. But it's a little bit, let's say, controversial, because they are expensive on one side, and still you might need to modify a little bit during the surgery.
Okay.
Yeah.
And last question is a bit like about the surgery itself, like clinical. Why is usually for a PSO the vertebral body, one vertebral body is usually cut and adjusted instead of having like a gradual cut like in more than one VB? Because this will reduce a lot the stresses, especially like for later, like for fatigue, for example.
That's a great question. Actually, PSO is one of the techniques. There are others. There is a point osteotomy, which is exactly what you said. So you, instead of creating a change of 25 degrees in one vertebra, you create 5 degrees in different vertebra. It's, let's say, little bit, take more time. And also it's, yeah, there are pros and cons, of course. Yeah, but there are many. PSO is the most common right now, so the surgeons prefer to go with the PSO route because it seems to be effective. But of course, yeah, also the others are used in the clinical practice.
And I guess maybe they would prefer to just tamper with one bone instead of multiple.
Yeah, there are many factors also for the access. You need to remove the muscles before performing the osteotomy. And if you do that in one level, you don't damage many levels because that takes more time. There's a bigger blood loss. Also, PSO has a huge blood loss. So it's really, yeah, really, blood loss is a great problem for this type of surgeries. I'm not 100% sure, but I think that the point osteotomy could be potentially even bigger, the blood loss. So yeah, there are many clinical factors, surgical factors, which influence the decision that you do. Yeah.
Perfect. Thank you so much.
You're welcome.
Actually, related to that, so a very important factor is the time of surgery. So the more you expose the internal tissues to the environment, the more risk you take at many levels. So that's every spine surgeon take this parameter very seriously.
Yeah, also for the infection. The infection is a big problem. If you make a bigger surgery, you have a higher risk of infection, which is, of course, a major factor.
Thank you very much, Fabio, for the great talk and all the modeling part that is quite impressive. One of the things that, let's say, when we talk about lumbar full spine model, most of the time the farthest we go most of the time is including ligaments, because of course they want for, let's say, stabilizing the movement of the spine. But I was wondering, what about the muscles? So let's say, of course, the ligament make a contribution, but also the muscle, let's say, if they activate or not activate, they might have influence in this. Could you comment a little bit about this, please?
Well, it's a huge topic, actually. So there are many studies recently trying to couple musculoskeletal models with finite element models to have a one-way coupling or two-way coupling in order to have the effect of the muscles, including in the model. I actually have one PhD student who is working on that. So he's developing an antibody model and then extracting the muscle forces and apply this force in an abacus model. There are still many, so these models are not robust yet. So we have many problems, and I'm not aware of any coupled model with patient-specific geometry or even deformities. It's quite, yeah, it's a great, let's say, future development, but I think it's still a little bit on the future side for now.
Hi. A question: after seeing how small was the sensor, about the pressure sensor that you had, and after seeing so many pictures with spine with so many screws inside and rods, and I was interested, I had this curiosity about, why don't you make implants that they have integrated pressure sensors? So when you, for example, you have so many screws in the spine or rods, all these implants have also pressure sensors integrated, so the doctors can have all the data from how the pressure were distributed in the spine. So when something breaks, for example, a rod, you can actually see how was the pressure distributed in the spine, and you say, okay, after these loads and under this flexion, you can say, okay, you have a 25% of breaking that rod. Wouldn't that be something?
Yeah, scientifically, it's hugely important and interesting. There are studies by the group in Berlin, Charité, Tony Ullman, they did the telemeterized implants with the strain gauges inside, so that you know the Orthoload website. So you can go on the internet, there is Orthoload website, you can really access videos of people with different type of implants and really see the video of people walking and see the forces and so on. Practically, in the clinical practice, I'm afraid it's going to be too expensive. Yeah. But scientifically, on a small set of patients, yeah, it's definitely relevant, and it has been done, indeed.
Hi, thank you for the talk. I was wondering if, because I saw in your presentation that you kind of tune different parameters like the diameter of the rods, or maybe try adding cages and so on. And this procedure, it was like trial and error. I mean, did you ever thought of doing some kind of algorithm that found like the optimal configuration for a certain patient or something like that?
Yeah, I thought about that. Yeah, I never had the time or the resources to try to develop something like that. But of course, yeah, it must be patient specific. That's not, there is no general solution for everybody. So it must be patient specific. So develop a framework to have all the reconstruction simulation. Yeah,
and this would be possible because maybe you need a lot of iterations and a lot of simulations, and computational is like very costly. So I don't know if you know of anyone that is doing something like that, or
I know some people who is working on something like that. Jess Snedeker in Zurich, they have a project going on in something like that. So it's an area which is being developed. Yeah.
Okay, thank you.
There any, Jérôme?
Yeah, maybe it's the last one because then we need to go to it. But that's a question that goes a little bit beyond your talk, Fabio. And thank you very much for presenting this very interesting actions in orthopedic surgery. So these models seems to bring a lot of information. Nevertheless, they have not really made their way through technology transfers as really clinical applications for design or prognosis. So large implant industries have actually adopted finite element modeling in order to internally test their design. So Medtronic, Zimmer Biomet is working on that. But in a clinical setup, so in order to really inform clinicians or maybe patients, so to help them make the decision, so there has not been tangible applications or products. So what is your view about that? What do you think can be the pitfall?
I don't really know, actually. I mean, it's clearly, I completely agree with you. Actually, I wrote 2 grants about this topic. I tried to implement something by myself, but it's a huge topic, and I still see quite a lot of problems or obstacles before. Yeah, we need something. Of course, there is the regulatory aspect, so that's something that needs to be approved and marketed. Then we need to have something which makes a business out of that, because that's not a solution that somebody will develop for free, of course. So there are many aspects and obstacles. We are far from that. I know that there is a company, Nuesch, I don't know if you know Nuesch, they have something already on the market and a prototype coming soon. I think that it's going in that direction. But it's still a little bit in the future. So we will see that. But I'm afraid that what we will see is coming from Medtronic, Nuesch, these companies, and not from the University of Academic Research. Yeah, they have probably bigger resources for developing something which is so complex.
Thank you.
Thank you very much. And I would say in the matter of time, thank you very much for your talk.